Hi, good day. My name is Nadia Kanhai, and I'll be presenting on pituitary apoplexy. The presentation was done by myself and Dr. Amrit Das. So we'll be going through the anatomy of the pituitary gland, going into details about the anterior and posterior pituitary, as well as the vasculature, the physiology of the gland, and then apoplexy itself and our guidelines to management. So we'll start off with the anatomy of the pituitary gland, which is an endocrine gland, ovoid-shaped in the cellotistic of the sphenoid bone, suspended from the underside of the brain by the pituitary infundibulum. It's made up of two lobes. We have the anterior and posterior lobe. The anterior lobe, the adenohypophysis, produces and secretes the majority of the pituitary hormones, which is under the hypothalamic control, whereas the posterior lobe, the neurohypophysis, doesn't produce any hormones, but instead releases two of the hormones that are produced in the hypothalamic nuclei. The pituitary gland itself produces the hormones that regulate a lot of vital body functions, body processes such as growth, metabolism, blood pressure, sexual maturation, and reproduction. The anatomic relations of the pituitary gland: anteriorly and inferiorly there's the sphenoid sinus, posteriorly the posterior intercavernous sinus, as well as the dorsum sellae, the basilar artery and the pons. Superiorly we have the diaphragm sellae and the optic chiasm, whereas laterally present is the cavernous sinus. The anterior pituitary is derived from Rathke's pouch, which is an outpouching of the roof of the pharynx. This makes up 80% of the weight of the entire gland. It's composed of glandular epithelium secreting many hormones: growth hormone, prolactin, follicle-stimulating hormone, luteinizing hormone, thyroid-stimulating hormone, and adrenocorticotropic hormone. It's further divided into three parts. We have the pars anterior, the distalis, which is our largest part, responsible for majority of the hormone secretion. The intermediate, which is a thin epithelial layer separating the pars anterior from the posterior lobe, and the tuberalis, which is an upward extension of the pars anterior surrounding the infundibulum. As I said, the release of hormones is under the control of the hypothalamus, which communicates with the pituitary gland via neurotransmitters, which are secreted into the portal vessels. The histology of the anterior pituitary, the distal part, has the strongest secretory activity, which contains three types of cells. The acidophilic cells are the somatotropes and the lactotropes, producing growth hormone and prolactin respectively. The basophilic cells are the gonadotropes, producing FSH and LH, the corticotropes, producing the ACTH, and the thyrotropes, producing the TSH. The chromophobes stay in weakly, and they are progenitor cells. The intermediate part, located between the anterior part of the adenohypophysis and the neurohypophysis, is mainly corticotrophic basophils at this point, producing melanocyte-stimulating hormones and endorphins. The tuberal part, the last part, extends from the anterior part of the gland, and it surrounds the infundibulum, as I said, and the majority of cells here are gonadotropes and thyrotropes. The posterior pituitary, it stores and releases both hormones, the oxytocin and the antidiuretic hormone. It's about 20% of the weight of the pituitary gland and consists of approximately 100,000 unmyelinated axons, which have neurosecretory bodies at the terminals of it, containing either the ACTH or the oxytocin, which are, as I said, both made in the hypothalamus. The release is controlled via unmyelinated axons throughout the infundibulum of the pituitary. Glial cells envelop these axons completely, forming the hypothalamo-hypophyseal tract lying close to the vascular sinusoids of the posterior pituitary. This facilitates the hormonal secretion into the bloodstream. The vascular supply. The anterior pituitary receives its arterial supply from the superior hypophyseal artery, which is a branch of the internal carotid, or the posterior communicating artery, forming a fenestrated capillary network around the hypothalamus, the median eminence, and blood from this specific network transported to a secondary capillary plexus, which surrounds the anterior pituitary. This is known as the hypophyseal portal system, allowing the hypothalamus to communicate with the anterior pituitary via the release of neurotransmitters into the bloodstream. The epithelial cells of the anterior pituitary are arranged between vascular sinusoids and cords, and this is where the hormonal exchange between the blood and the neural tissue occurs. The posterior pituitary, the infundibulum and the posterior pituitary gland has blood supply both from the superior hypophyseal artery, infundibular, and mainly the inferior hypophyseal artery. Both for the venous drainage, both the anterior lobe and the posterior lobe have the same drainage, which is the anterior and posterior hypophyseal veins into the cavernous sinus. So our pituitary hormones, we have the list. We have ACTH, prolactin, luteinizing hormone, FSH, growth hormone, TSH, and the posterior oxytocin and ADH. They all have many different functions, which are outlined in this slide. So now we could go into detail on pituitary apoplexy. So pituitary apoplexy is a medical and a surgical emergency involving infarction or hemorrhage of the pituitary gland, most often in a pre-existing pituitary adenoma. The incidence with adenoma symptomatic is about 10%, whereas asymptomatic, we have 26%. Most of the times, in 80% of patients, pituitary apoplexy is the first presentation of an underlying tumor. There's a higher risk involved with larger tumors, more than 10 millimeters, as well as in tumors that demonstrate rapid growth. There's a male to female ratio of 2:1 and approximate age range of 37 to 57 years. We have many precipitating factors, most significant seen to be systemic hypertension. There's also major surgery, dynamic pituitary function tests, anticoagulation therapy, coagulopathies, estrogen therapy, initiation or withdrawal of a dopamine receptor agonist, radiation, pregnancy, and head trauma. Our clinical manifestations, the symptoms mostly involve the acute expansion of the tumor itself from hemorrhage. There are both hormonal effects and visual effects. The hormonal effects come about because of the sudden interruption of the release of hormones, whereas the visual effects result from the direct compression of the optic chiasm or the optic nerves. Several causes of ischemia, necrosis, and hemorrhage have been documented. There's the compression of the superior hypophyseal artery and its branches against the diaphragm ocelli, causing ischemia of the anterior pituitary gland and the tumor, as well as the thin pituitary vascular network being compressed as it's located inside a small intracellular compartment, causing ischemia, necrosis, and hemorrhage. And the last is that a rapid expansion of the tumor itself outgrows its vascular supply, leading to ischemia and necrosis. Of note, there's Sheehan syndrome, which is postpartum pituitary necrosis. It is associated with necrosis of the pituitary gland secondary to ischemia from bleeding during childbirth, manifesting as hypothyroidism, adrenal insufficiency, hypopituitarism, and it rarely has visual changes involved. The most common initial symptom observed is a difficulty or an absence of lactation. In our symptoms or history, the most common presenting symptom of pituitary apoplexy is a sudden onset generalized headache behind the eyes, and this is from involvement of the superior division of the trigeminal nerve inside the cavernous sinus, as well as diaphragmatic compression, meningeal irritation, or cellar wall enlargement. There's also nausea or vomiting. Patients can present with decreased visual acuity, visual field defects, ptosis, diplopia, hemianopia, pupillary dilatation, and lateral eye deviation, ophthalmoplegia, altered mental status, and hormonal dysfunction. In more than 2/3 of patients, the most impactful significant thing is the lack of secretion of ACTH itself, which causes cessation of cortisol secretion by the adrenals, leading to an adrenal crisis, which is a severe and life-threatening event. Symptoms involved are nausea or vomiting, abdominal pain, hypotension and bradycardia, lethargy, and even coma. A clinical assessment for pituitary apoplexy would involve a detailed history, cranial nerve examination, visual field assessment, as well as blood samples for baseline endocrine function tests. In our workup, the hormonal evaluation would be a measurement of the pituitary hormones. The most common abnormality seen in pituitary apoplexy in 90% of patients is growth hormone, and in 70% it's ACTH. Blood samples can be done as random cortisol, prolactin, thyroid function tests, insulin-like growth factor 1, growth hormone, luteinizing hormone, FSH, and testosterone in men, whereas estradiol in women. For imaging, An X-ray can be done, which would show an enlargement of the pituitary fossa and erosion of cellar floor and the dorsum celli, as well as a fracture of a dorsum celli. A CT head would show a cellar or supracellar mass with intralesional hemorrhage. Contrast can delineate a size of a tumor, but otherwise a non-contrast CT head cannot identify necrosis or ischemia. An MRI brain is the diagnostic imaging modality of choice for pituitary apoplexy. Subacute and chronic situations, more than 12 hours, are specific. Ischemic, one would see an enlarged cellar or supracellar mass with peripheral enhancement surrounding a hyperintense center. On diffusion-weighted imaging, one can identify the consistency of the tumor as well as ischemic tissue that occurs after arterial occlusion. In a hemorrhagic pituitary apoplexy, on T1-weighted MRI, a cellar or supracellar lesion would be seen with intralesional areas of high signal intensity. T2-weighted MRI would be sensitive to deposits of hemosiderin. Initial management is immediate resuscitation, correction of electrolyte imbalances with IV fluids, assessment and addressing any hemodynamic instability. For corticosteroids, we initially bolus 100 to 200 milligrams IV hydrocortisone, then 50 to 100 milligrams every 6 hours, or an infusion of 2 to 4 milligrams per hour. Once the patient is stabilized, a tapered maintenance dose can be used of 20 to 30 milligrams daily. In pituitary apoplexy, care can be done via conservative or surgical management. Conservative management can be considered in our patients that present without any visual field defects or with a normal consciousness level. Emergency surgery is performed in cases of decreased consciousness level, hypothalamic involvement, or in cases of visual worsening. The options are microscopic endonasal or sublabial transsphenoidal surgery, which provides a better endocrinological outcome, and craniotomy and resection for large tumors or those that extend over the chiasm or laterally to the temporal lobe. Complications can be visual loss, adrenal crisis as mentioned, ophthalmoplegia, increased intracranial pressure, ptosis, bilateral cerebral infarcts, and diabetes insipidus. The mortality of pituitary apoplexy has been documented to be approximately 1.6 to 1.9%. For both conservatively and surgically managed cases, visual improvement, recovery of normal vision, and rectification of oculomotor palsies have all been observed after the incidence of the apoplexy. In 80% of cases of gross total resection, hormone replacement is needed in these patients. 4 to 6 weeks after the incidence occurs, assessment of pituitary function should be done, as well as assessing visual acuity, eye movements, and visual fields. An annual pituitary function test should be performed. 3 to 6 months after, an MRI should be done to evaluate for residual tumor, then surveillance annually for the next 5 years, followed by every 2 years after. These are my references, and that is all for my presentation on pituitary apoplexy. Thank you.